Gout is a type of crystal arthropathy, which is associated with chronically high levels of uric acid in the blood. Crystal refers to the fact that urate crystals is what causes the problem, and arthropathy refers to the fact that the problem is in the joints. So what happens is urate crystals are deposited in the joint, and this causes the joint to become hot, swollen, and painful. Gouty tophi are subcutaneous deposits of uric acid under the skin rather than in the joint, and these subcutaneous deposits typically occur around the small joints and connective tissues of the hands, the ears, and the elbows. The DIP joints, or the distal interphalangeal joints at the ends of the fingers, are the most affected joints in the hands. Gout typically presents with a single, acute, hot, swollen, and painful joint. The obvious and extremely important differential diagnosis is septic arthritis. And septic arthritis is quite dangerous to the joint and can be very destructive. So it's important to treat a hot, painful, swollen joint as septic arthritis initially until it's proven not to be related to an infection. So what are the risk factors for developing gout? It's very important to identify the risk factors because gout very rarely occurs in people without risk factors. However, people who have many risk factors are much more likely to get the condition. So the risk factors are being male, obese, having a high purine diet. So this is a diet high in meat and seafood and other things containing purines. Alcohol is a risk factor. Using diuretics like thiazide diuretics, having existing cardiovascular or kidney disease, and having a family history of gout. There are a few typical joints that are affected in gout. The first is the base of the big toe, and this is the metatarsophalangeal joint of the great toe. The second is the wrist, and the third is the base of the thumb, and this is the carpal metacarpal joint. Gout can also affect the big joints such as the knees or the ankles. So how do we establish a diagnosis? Well, gout is usually diagnosed clinically or by aspirating fluid from the joint. It's really important to exclude septic arthritis as this is a potentially joint and life-threatening diagnosis. When you aspirate fluid from the joint, in gout you'll see no bacterial growth. If there's bacterial growth, this is septic arthritis rather than gout. In gout you'll also see needle-shaped crystals, negatively birefringent of polarized light, and on further investigation you find monosodium urate crystals. There's also some typical gout X-ray changes. In gout, the joint space is usually maintained on the X-ray. You can see lytic lesions within the bone. There can be punched out erosions, and the erosions can have sclerotic borders where there's some hardening or whitening of bones, and there can be overhanging edges where the edges of the erosions hang outwards over the top of the erosion. So how do we manage the condition? Well, there's two aspects to management. Firstly, managing an acute flare when the patient is in pain with a red hot swollen joint. And secondly, providing prophylaxis to reduce the risk of a flare. So during an acute flare, the first line treatment is non-steroidal anti-inflammatory medication like naproxen or ibuprofen. Colchicine is a second line option. And third line, where both of the above fail, is to consider steroids. Colchicine is used in patients where NSAIDs would be inappropriate, such as patients with renal impairment or significant heart disease. A notable side effect is gastrointestinal upset, particularly diarrhea, which is a very common side effect. The diarrhea that you get with colchicine tends to be dose dependent, so that if you're on a lower dose, it causes less upset than at higher doses. So if a patient develops diarrhea, try reducing the colchicine dose and see if that improves the symptoms. The second aspect is prophylaxis, and the one medication you need to remember is allopurinol, and this is an xanthine oxidase inhibitor that's used for the prophylaxis of gout, and it works by reducing the uric acid level. It's also important to advise the patient about lifestyle changes, which can really help to reduce the risk of developing gout, and this involves losing weight, staying well hydrated, and minimizing the consumption of alcohol and purine-rich foods such as meat and seafood. A quick Tom tip: don't initiate allopurinol prophylaxis until after the acute attack has settled, but once treatment with allopurinol has been started, then it can be continued during an acute attack. This is quite a common exam question and a useful piece of knowledge to remember.